call Dr. D.P. Sinha to discuss about the side branch preparation calcified lesion. Dr. D.P. Sinha, please.
It will be seen only in the moving views. But if it's seen only in static views or without cardiac motion, it is usually severe. Please remember, calcium not seen on angiography is usually very mild, does not need any modification, with some exceptions. And intravascular ultrasonography, if it is a calcium mark is more than 270 degrees, it is considered severe, and its length more than 5 millimeters, it is considered severe. And OCD criteria, you are all aware. We have a case, this is a severe calcification in the proximal and mid part of LED with involving the origin of a major diagonal branch. Now, why is calcium important? Because it causes under-expansion of the stent, it causes nihil opposition, it causes damage to polymer coating, and that leads to variable anti-proliferative drug effect, and that leads to increased mass. So these are the various devices that have been used in managing the calcium. Either it can be the rota, or it can be the orbital atherectomy, or ELCA, or latest is the acoustic modification. It can be balloon-free method by rotablation, orbital atherectomy, or by external laser coronary angioplasty, or it can be balloon-based by a modified balloon, which is either a cutting balloon or a scoring balloon, or a very high-pressure balloon, or by intravascular lithotripsy. A rotational atherectomy has its advantages that it can be used to treat extremely calcified, non-crossable or non-dilatable lesions. This can be used as a primary or a bailout strategy. Rotational atherectomy has been available over the last 30 years or so, and everybody knows its uses and disadvantages. The disadvantages are it has got a significant learning curve. It cannot be used only two angulated lesions, often leads to slow flow or no flow, and particularly in a dominant RCA or a dominant circumflex, it can give rise to conduction disturbances. And there are reports of perforation, dissection, or bar entrapment. To overcome all of these came orbital atherectomy, which can do an atherectomy both front and backwards, and it gives rise to pulsatile impact of the crown, causes microscopic fractures of the deeper calcium, which is an advantage in comparison to rotablation. And similar to rotablation, it can be used as a undilatable lesion. It can use with a single bar, you can go for 2.5 to 4 millimeter diameter, and there are less chances of crown entrapment, and there are reportedly less smaller debris, causing less chances of no slow flow or conduction disturbances. But its drawbacks are it has got a significant learning curve as well, and its cost is significantly higher. If you can get out rota using a single bar, it is cheaper than orbital atherectomy. And there is a lack of data, though their data is being generated. And XMR laser coronary angioplasty is recently available in India. It uses xenon chloride laser, which works by photocoagulation, photothermal and photokinetic effects. The power of the laser can be increased manifold by what is called an explosion method, which is basically you inject a contrast while using the laser, which causes bubbles and causes fracture of the calcium. Its main indication are non-crossable lesions and stent under-expansions. But data on calcified coronaries, I have not got any. And the one beauty of it is that there is a less risk of coronary dissection. The balloon-based methods, you are all familiar. They are cutting balloon like Wolverine or scoring balloons. The advantages are minimal learning curve, but all of them has got a high profile, so are difficult to cross. And there is a risk of coronary rupture as well. Very high pressure balloons are recently being used. You can safely go up to 40 atmosphere. Success rates are very high. The disadvantages are they are also very high profile. And the registry, when compared to the non-compliant balloon, it was shown that if the calcium mark is more than 270, this very high OPNNC works better than a non-compliant balloon. In that registry, incidence of coronary rupture was low, even going up to as high pressure as 40 atmosphere, but it was more related to the calcium characteristics of the lesion. And the latest kid of the block is the intracoronary lithotripsy, in which a semi-compliant balloon, which has got an electroacoustic system built in it, which generates sound pulses with a force of 50 atmosphere. It can cause controlled breakdown of both superficial and deep calcium. Its use in complex setting, particularly bifurcation, is relatively scarce. Its use is best exemplified in the underexpanded stent, and main disadvantages are it has got a reduced crossing profile and is difficult to use in diffuse or multivessel disease, particularly because of its cost. It has got a very good data so far as safety is concerned. Disrupt CAT3 trial, when compared to orbital atherectomy or rotational atherectomy, either the prepare calc or the Rotaxas trials showed that it's got a significantly less morbidity in the use of this IVL balloons in calcified lesions. But the Achilles is still there. IVLs have not worked properly in patients with bifurcation lesion. It has got a negative point. In bifurcation lesions, IVL efficacy is much lower than in a single vessel disease. You combine the different techniques like rota cutting or rotatripsy, but the data is not very much data is there. The approach is this, that you modify the superficial calcium by rota, and a deeper calcium can be prepared by a cutting balloon or an IVL. Now coming to our patient, what was done is this, that a rota was used to prepare it, then a cutting balloon was used. We have deliberately gone for a provisional stenting strategy. Of course, after using the cutting balloon, we had a significant long dissection, which was covered by 2 stents, and finally an OCT was done to complete the procedure. But what about the last part of the problem? What about the calcification and bifurcation? What kind of bifurcation should be considered? It has been recently established that a side vessel which is more than 73 millimeter long and has got a lesion length more than 9 millimeter is a vessel you should worth preserving. And the presence of extensive calcium at bifurcation is a marker of poor outcome. The carina is typically spared from atherosclerosis, as you all know. The reduced compliance of the wall opposite to the carina causes carina shift because of lower resistance encountered by the inflated balloon. So this was the situation where a prepare calc trial which used rotablation to study the effect of rota on calcium, in a subgroup was studied in which 41% patients had lesions at bifurcation. But in that very advanced center, lesion preparation of side branch using scoring balloon or a rotablation was performed only in 6.3% and 2.9% only. Very procedural side branch compromise was higher in modified balloon group compared to the rotablation group, and side branch compromise was led to higher troponin I levels. How do we manage a severely calcified bifurcation lesion? You put in a double guide wire both in the main vessel and the side branch. If it is crossable, a rotoplasty or a modifying balloon or a lithoplasty, go for a PCI. If it is uncrossable, remove the side branch guide wire, do an atherectomy, and do a PCI DS. So in summary, calcified coronary artery bifurcation lesions remain a challenge for the interventional cardiologist. Evidence regarding treatment of coronary bifurcation lesions calcified is minimal. Optimal plaque modification is the most important step prior to stent deployment. Provisional stenting is the preferred strategy for most bifurcation lesions. However, 2-stent strategy should be considered for bifurcation lesion compromised with a large side branch, supplying a large territory. More than 70% of the side branch stenosis and lesions more than 5 millimeter long. And lastly, I welcome you all to Kolkata from December 7 to 10 for the Platinum Jubilee CSI Con 2023. Thank you.